implementation practice and implementation research capacity in the primary healthcare in Tanzania. So we'll be discussing about the transformative roadmap for the change. So the aim of this forum, as we know, throughout the global, the governments and the healthcare systems are facing significant challenges in providing the equitable healthcare services. So we have some challenges to do with implementation globally, and currently we are stretching across different parts of the health system over the past decades in order to achieve the universal health coverage. So implementation research has been put forward as a crucial in global health as it tackles the so-called no-do gap. So with implementation research, we are going to gain more attention, resulting in a better understanding of what affects implementation and how implementation can be planned in the field, and how we can see the shared understanding for the clear way forward to close or to bridge that gap. Further, as we build the capacity, more efforts have been directed toward building capacity for implementation by training researchers, healthcare professionals, implementers through various levels on evidence-informed implementation. So the aim of this forum will be to share the roadmap. We have developed the roadmap for implementation practice and implementation research, but again we have the SOPs for implementation practice and implementation research. So today we are excited to have the great speakers with us. Number one will be Dr. Grace Magembe. Dr. Grace Magembe is a medical doctor who has worked as a consultant commission on information and accountability for women and children health at WHO Geneva. But again, Dr. Magembe has worked as a municipal medical officer and a program manager for reproductive, maternal, newborn health for Ambulance Health Africa. But again, she has worked as the RMO for Dar es Salaam, but again the Director for Curative Services at the Ministry of Health, the Deputy Permanent Secretary at PO-RALG, as well as the Deputy Permanent Secretary for the Ministry of Health, and currently she's the Deputy Permanent Secretary at the PO-RALG. So Dr. Magembe this morning is not with us, but will be represented by Dr. Mfaume. So please, Dr. Mfaume is a seasoned public health specialist with over 19 years of experience in the primary health care, focusing on community, maternal and child health, but again disease prevention. He holds a Doctor of Medicine, Master of Public Health and Master of Business Administration, with 7 years serving as the RMO and 12 years as the District Medical Officer. So Dr. Mfaume is currently the Director of Health, Social Welfare and Nutrition Services at PO-RALG. Please, Dr. Mfaume, you're welcome. Take the stage. Our next panelist will be Dr. Ulka Becker, who will just give us the keynote address. Dr. Ulka is the health manager for the primary health care, working with UNICEF Tanzania since 2019. She has a background as a medical doctor with Master of Public Health from London School of Hygiene and Tropical Medicine. She worked extensively on the health system on the quality of maternal health, newborn care, as well as a clinician, a public health practitioner, a researcher, and a lecturer in various sub-Saharan African countries for the past 20 years. And she worked in various countries including Eritrea, Uganda, Malawi, and Tanzania. So please a round of applause to Dr. Ulka as she marches forward. Karibu sana Dr. Ulka. The next will be Dr. James Kengia. Dr. James Kengia is a principal dental surgeon and a seasoned public health specialist. Currently, Dr. James Kengia serves as the coordinator for research and publication at PO-RALG with a background spanning in hospital management in various healthcare roles. He holds the PhD in public health in leadership from the University of Tokyo Medical and Dental University in Japan. Dr. James' expertise extends to teaching at the University of Dodoma, where he imparts knowledge in the health system and management, health economics, and leadership since 2017. Dr. James has over 42 publications. So please a round of applause to Dr. James Kengia. Karibu sana Dr. James. Another speaker is Dr. Irene Haure. She is a medical doctor since 2013 and a public health specialist. Graduated from the University of Washington this year, and she served as the DMO for High District and Temeke Municipal since 2016 and 2023. Currently is working at PO-RALG as the quality coordinator at the primary health care. Karibu sana Dr. Irene, makofi mengi kwake tafadhali. Another speaker will be Professor Albino Karoro. Professor Albino Karoro is currently a principal of St. Francis University College in Ifakara. He has the expert in implementation science, in health economics and health financing. But again, he has the background in epidemiology and health policy. Professor Albino Karoro graduated as a medical doctor from the University of Dar es Salaam, Masters of Business Administration in Netherlands, and PhD in Public Health, specialized in healthcare financing at the University of Heidelberg in Germany. So currently, Professor Karoro has over 74 publications pertaining the implementation science. So Professor Albino Karoro is not with us, but I think he'll join us soon. Makofi mengi kwake tafadhali Professor Albino Karoro. The next is Dr. Kasusu Clinty Nyamliukenge. Kasusu is a dental surgeon who is also a researcher and a lecturer at the School of Dentistry at the Muhimbili University. He graduated as the Doctor of Dental Surgery in 2009 at MUHAS. He holds a postgraduate diploma in global health from the University of Temple in 2009 and the MPhil in international health from the University of Bergen in 2012 with a PhD in public oral health, which focused in health economics from the University of Turku, Finland. So currently he is involved in implementation research in the areas of community health and the quality of maternal and newborn care in Tanzania. So a round of applause to Dr. Kasusu Clinty. Kasusu, karibu sana. The next is Ms. Chipore Yusuf Perembe. Chipore is a senior health system specialist who is currently working at the PO-RALG. She holds a Master of Science in Project Management, Monitoring and Evaluation in Health. But again, she holds the Masters in Business Administration. She is a certified in Organizational Development and Governance. Karibu sana Ms. Chipore, can take your seat. So, to start with, let me take this opportunity to welcome Dr. Rashid Mfaume, just to speak the welcome remarks on behalf of Dr. Grace Magembe, who was supposed to be with us this morning, but he has another task that he was being given, and she'll be here as we move forward. So, Dr. Mfaume, karibu sana.
Good morning. So I greet you in the name of the Republic of Tanzania. Saying na kazi endelee. Na wasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. So on behalf of the Deputy Permanent Secretary, Dr. Grace Magembe, who was supposed to deliver this brief speech on this forum, and for the reasons that the moderator has already provided us, I'm going just to present in very brief summary what she intended to speak to as a welcoming note, if she would manage to be with us this morning. So, ladies and gentlemen, I did otherwise from Deputy Permanent Secretary Dr. Grace Magembe. So I'm not Dr. Grace Magembe. I'm standing here on our behalf. So I greet you all in the name of the Republic of Tanzania again, and I'm profoundly delighted to be here today in this very important event, and in particular to welcome you all to participate in this forum. And the title of this forum is Developing Implementation in Practice, as Pius has said, and research capacity in primary health care. The way primary health care should be underlined. A roadmap for change. The word roadmap for change in terms of implementation in practice and the capacity of information research will be repeated now and then. My special thanks goes to all partners organizing, but all partners present here today for your ongoing support to the government of the Republic of Tanzania in different health, nutrition, and social welfare interventions, as well as economic development initiatives geared towards attainment of SDGs. Dear participants, over the past years, the government of Tanzania, in collaboration with the partners, has been putting a lot of efforts to improve the capability of primary health care. Nevertheless, much is still to be done to improve further health systems, responsiveness, equity, health system resilience, overall quality of services, and universal health coverage at large. Our Excellency, the President of the United Republic of Tanzania, Dr. Samia Suluhu Hassan, on 30th September 2023, has reiterated this in her speech during the signing ceremony of the Nutritional Compact Agreements with the regional commissioners, and has directed us, among other things, to focus on improving the quality of healthcare services. Dear participants, the role of implementation research and practice is very important for the realization of this strategic thinking of our presidents. I'm certain that this forum will deliberate on strategic and operational issues for developing further our capability towards conducting implementation research and practice, hence contributing to the betterment of the quality of health, nutrition, and social welfare services, and the realization of the national and international goals toward the attainment of the SDGs. Dear participants, over the past decades, universal health coverage also has been proposed to require the development of contextualized evidence in the search for local solutions and innovations, building implementation research and practice, as well as implementation research capacity, is therefore crucial in global health as it tackles the so-called not-to-do gap. This was once said by the moderator. By addressing the practicalities of achieving health goals, it is evident that all critical gaps, including health joint efforts through partnership, that all stakeholders for the health, social welfare, and nutrition services share a common vision of the challenges and opportunities so that we can together prioritize areas in which intervene, accelerate the attainment of health, social welfare, and nutrition services related to SDGs. The government is committed to our partnership, and we will continue supporting the work that has been done by all stakeholders in the country. There is some much we can learn from each other and achieve together for better health, social welfare, and nutrition services all. Let me conclude by once again welcoming you all to this forum and hoping that we will discuss and share our understandings in the subject matter and deliberate together on key issues to move forward. Asante sana.
Thank you very much, Dr. Rashid Mfaume, on behalf of Dr. Grace Magembe. So at this time, we want to hear from Dr. Hulka Becker from UNICEF, who will provide the keynote address for the forum in order to create a better understanding of the subject matter and stimulate the discussion from other discussants and from the audience. So please, Dr. Hulka, you have your 10 minutes at least to create a better understanding of the subject matter. Karibu sana, Dr. Hulka. So you'll be noting some questions after the discussants. We'll just receive the questions for them to respond.
Hello. Habari za asubuhi. Pole na joto. I'm going to try not to fall off this stage. I tend to move a bit when I speak. While I'm waiting for my colleagues to set up the presentation, and everybody left. Oh, they are coming to look. I'm really honored to be invited to say a few words on this topic, which is very close to my heart, and which is something that I've worked closely with colleagues at TAMISEMI, at various academic institutions for many years. And I'm going to, here we go. I'm going to share with you a few slides to kind of set the scene. And actually, I think it's really great that this is the first forum of the conference. And I hope that you will keep some of the messages at the back of your head as you go through the other forums and presentations this week, because this is really cross-cutting. I'm going to talk about four things. I want to briefly talk about the rationale. Why are we talking about this? And I think it's been made clear both by our moderator and by Dr. Mfaume. I want to talk a little bit about the science of implementation. We actually know a lot about what works when it comes to implementation, but very little of that is used. I want to define a little bit our terms. What are we talking about? What do we mean implementation research, implementation practice? And then to talk about the roadmap that we're thinking about in Tanzanian primary healthcare and how can we apply these concepts to improve the quality of our services. Okay, so the first thing is, what do we mean implementation? Implementation, I think, is something that most of us in this room feel is something we do every day. The microphone is not my friend. It's really the process of putting policies, strategies, health interventions into practice. It's not something that a clinician does in the clinic only. It's something that we do all the way up to policy level. Can someone? Maybe I need to move. Let's see how that works. So it's really about what we do at different levels of the system. It's not something that someone else is doing. Actually, all of us are involved in it. And it's about bridging this gap. And my colleagues have already spoken about this. They've mentioned the no-do gap. We have a policy to practice gap. We have an evidence to policy gap. We have an access and quality gap. We have lots of gaps that we're dealing with, which are essentially about what we think we should be doing, and maybe what we've decided we should be doing, and what we're actually doing. And this is what we're talking about today. So I want to show you just this one slide on the rationale, just to set the scene also in a global context. In front of you, you have something called the World Health Chart from Gapminder, which is a free source that you can look at online. We have child mortality on the y-axis, and we have GDP per capita on the x-axis. And you have all the countries in the world here, and you can see, in general, as countries get richer, they move along this side, the child mortality also declines. And where do we have Tanzania? Some of you will be wondering, where is Tanzania? And it's not there. It's there. I don't know how many of you guessed. And just to give you a few markers where other countries are, you can see that some countries, despite having more money, actually have higher mortality. And we can also see that some countries with comparatively lower GDP have lower mortality compared to the other countries. And this is all to do with how we prioritize, how we make sure that effective interventions that we know can prevent and save lives influence these statistics. And a few years ago, there was a big commission. The Lancet, which is one of the world-leading medical papers, they did a big commission on high-quality health systems. And they concluded that in low and middle-income countries, mothers and children receive less than half of the recommended clinical actions that they need in order to thrive. And that poor quality of services is actually a bigger challenge for us in access. And I think this is something we know in Tanzania. We know that 81% of our babies, according to the latest Tanzania Demographic and Health Survey, are born in a health facility, but not all of those who are born receive all of the care that they need. So we're grappling with this stagnant newborn mortality. And if you look at across Tanzania's region, we also know that there is a huge difference. It's a little bit far maybe for you to see, but there are some key interventions here: antenatal care attendance before 4 months, health facility delivery, signal functions for newborn care, vaccinations, met need for family planning among adolescent girls. And you see the gap in coverage between the regions. So we have implementation, we can measure the implementation challenges in these national indicators. So what do we then know about? So we agree that there is a gap, and we have the possibility to change this gap because there is already evidence on the interventions that we know can prevent illness and save lives. But how do we make that happen? How do we change practice? And my friend down here, he says, let's do a training. And I think this is often what we do. We see that something is not happening, so we decide to do a training. I think many of you will recognize that. But many of you will also recognize that quite often we do a training, but then we don't really see any change. And already 25 years ago, researchers said that decision makers planning interventions to translate scientific evidence to clinical practice often adopt a simplistic and opportunistic attitude. A single strategy is often chosen quickly and often does not produce the required results. So in this case, with training, it's not that we don't need training. We need that. One of the fundamental pillars of changing practice is the capacity to do that practice. But we know that it doesn't translate into a change in behavior by itself. What we also need is the opportunity to do that practice, to translate the capacity into practice, and we also need to be motivated. I may have all the knowledge I need, I may be in a position to provide the practice, but nobody really cares or notices whether I do it at any level of the system. So this is what you see in front of you, is something called the COMB model, the capability, opportunity and motivation for behavior model, which is one of the most widely used in health sciences. But so in terms of implementation science, what do we know about what works? It really depends. So it depends, what are we trying to implement? Are we trying to do something which is quite simple? We are just introducing maybe a new lab test, a new rapid test for malaria, for example. Or are we trying to implement a whole national health policy, or a complex treatment protocol? It really depends. And it depends how the people who are supposed to do it perceive that intervention. It depends who is the implementer and who is benefiting from that implementation. What are their needs and capacities to do this? Where is this taking place? I was just discussing with a colleague this morning that we frequently see very different outcomes from doing the same thing in different settings, and we know this, and we can measure it, that context matters. It depends on the organizational culture. Maybe we have a team, a hospital that's really driving change, whereas another one, we can't be bothered. So it really depends. Is there a tension for change within the organization? And how is it carried out? And this is now getting to the crux of implementation research. We might know what to do, and who to do, and where to do, but how to do. And we talk about it a lot, but how to actually translate that into activities and practices is another thing. And I wanted to show you this. There's actually a number of studies that have looked at how effective different implementation strategies are in healthcare. And we can see that, you have a few here, I think you are familiar with all of them. The first one is printed information, usually typically guidelines or job aids. If you implement that on its own, it has very little effect. Very little effect. But we focus a lot of our efforts on doing that. We spend money and months to develop guidelines, to develop the most perfect and well-designed job aid, and then we hand it out, and then not much. ICT interventions, which is also very popular, on its own has very little effect. Training has a moderate effect, but not a large one. And these are small effect sizes if you're into the science, and I'm happy to provide you with the background reading. I'm almost falling off. Supervision, group problem solving, and are also moderate effects, whereas financial incentives also on the fence. What we do know is that if we combine strategies, we are looking at a problem in our setting, and we think about all the dimensions around the capacity, opportunity, motivation, we can have large effects, and we can see change. So in these particular cases, it was infrastructure improvements combined with supervision and other management techniques and training, or group problem solving and training. So training together with other things can really do something. So what do we learn from this? What we know is that we need to tailor the implementation to the change we want to see, and we need to define what it is we're doing. We need to measure how many training sessions, where, involving who, with what frequency, and so on. defining our terms.
3 minutes.
Say again.
3 minutes.
3 minutes. You will give me a few more. Yeah. It also depends on the stage. You know, is something new? Are we exploring something? Is it just at the beginning? Is it something that has started, or is it now on a national scale? And depending on which stage, we're looking at different things. And these are the implementation outcomes that we look at in terms of implementation practice and research. So I'm going to go quicker, and those of you who are interested can look at I'm happy to share the slides. But together with PO-RALG, the team at PO-RALG, we have been looking at how can we operationalize this thinking for the benefit of primary health care in Tanzania. Is there a way that we can make this less external, less scientific, less academic in a way, although not to deter my fellow academics, but how can we make sense of this? And what we found are these two operational definitions that are still still being discussed. But implementation research in primary healthcare in Tanzania would be the systematic generation of evidence on the factors influencing current and desired practices and the application of evidence-based strategies to improve their implementation in primary healthcare systems. And for practice, it would be the purposeful use of evidence to develop, apply, and monitor implementation strategies to bring about a desired change in practice. So the two go together. And why are we then thinking about a roadmap? And you can hear that I'm speeding up because I've been told I'm running out of time. It's really to build on other initiatives that are also present in the country, to build a culture of evidence-based implementation practice in primary healthcare, and to institutionalize continuous learning from and improving this practice through embedded implementation research and data use at all levels. And I know we have many RMOs in the room and colleagues from different levels of the health system. Tanzania has a very strong structure for its health system at different levels. There are many structures with their functions and routine processes in place. This is actually a map that was done a couple of years ago to identify the entry points. Where could we use the thinking that we have with us from implementation science in this setting? So the idea is not to create something new, but is to look at where in this big puzzle could we inject what we know about implementation science and practice to enhance the processes. And Piers, will you give me 2 more minutes? Yeah, because I think then the discussion will make more sense. So I just want to pause a little bit on this. Let me move over here to see if I can get a bit further away. Hello. So here we have our definitions, implementation research and implementation practice. So what would this actually look like? Well, the starting point for both of this is really to identify an issue, some sort of practice to be improved or an implementation challenge to be addressed. And on the practice side, we would say that in many cases we already have evidence, or it's not really feasible to do research. We just want to try and improve. And this happens a lot at the lower level of the health system when we work with quality improvement, for example. So we gather available evidence and information to inform a new strategy, and hopefully at this stage it will be more about what works depending on what we want to try and achieve. We want to develop implementation strategy, we want to implement and monitor, and we want to disseminate the results. You probably can't see that. On the research side, when we have a situation where maybe we're trying to do something new, or we need more evidence, this is when we link up with our academic colleagues to develop an implementation research plan, collect data, and interpret results and develop actionable recommendations. And this would then feed in to the practice and also go to dissemination. And at the bottom here, which you probably can't see, the idea is that on the implementation research side, we're not proposing that everyone should become an academic. But we would like our colleagues who are primarily engaged in implementation to understand a little bit what it's about, to engage more effectively and be part of the process. But here it says researchers lead and implementers, practitioners engaged. And on the other side, implementers and practitioners lead, but the researchers can engage. I see some of you taking photos. Please, we can share this device. So we have a roadmap for change, and this will be my last slide. And why are we working on this? Now I'm going to walk down here and see if I can get even further away from the speaker. So what we're trying to do is to improve the quality of primary healthcare services. This doesn't have any other objective. We're not trying to do something else or something new. This is just a different pathway. And we think that the kind of outputs we're looking at from this roadmap is increasing the knowledge and skills, both in terms of implementation, practice and research. We want to create opportunities to apply that capacity through the routine platforms in primary healthcare. We want to establish connections between the implementers and academia, and we want to also generate opportunities to disseminate through different fora. And we have a number of things, how we think that should work, but overall we're looking at both the capacity of the system, the opportunity and the motivation to do this. So this is my last slide, and seeming as I work for UNICEF, this little boy is telling us what to do next. We're going to finalize and validate the roadmap that has been developed. We have developed SOPs for these different routine structures, and I hope that some of you will be involved in piloting them to see how we can really translate this thinking into action, and also develop a plan for what kind of capacity building is needed to implement this and to mobilize, but also leverage resources. We're really hoping to see that the thinking can be built in to many other places. And now, my moderator is getting nervous, so I'm handing over.
Thank you very much, Dr. Luca. So please, my moderators, you can just take your seats so that we just continue with the discussions. So just keep your questions. We'll have that session, and you'll be required just either to ask in Swahili or in English, so whatever you can just use. So next, Dr. Rashid, as the Director of Health, Social Welfare and Nutrition Services at PO-RALG, with a mandate to oversee the implementation of various policies and guidelines that are developed by the Ministry of Health Tanzania, how do you see the potential of implementation research and practice to support your work? Would you please elaborate your view on the importance of having that roadmap as presented by Dr. Ulka?
Thank you, moderator, and once again, good morning, participants. Thank you very much, Dr. Ulka, for a very well presented keynote. And as a Director of Health, Social Welfare and Nutrition Services at PO-RALG, I really feel privileged to be one of the panelists. Now, the role of PO-RALG, among other roles and functions, is to make sure that the policies, strategies, policy guidelines, regulations related to health are clearly translated and put into action. Now, in this context, are put into, let me use the word implementation, as you clearly defined. And implementation is not just doing, but what is really known, put into actions. So as a PO-RALG, we make sure that what is being implemented at the subnational level, what is being implemented by the different partners, implementing partners, donors, really align with the national policies as formulated by Minister of Health or other relevant responsible ministries like Minister of Community Development, Gender, Elder and Special Groups, and the Prime Minister's Office, because they have been also formulating policy and policy guidelines. So, as Director, what you have been observing also is how now, on our today task, at all levels, at the PO-RALG headquarters, at the regions, led by the RMOs and the districts, while, for example, the facilities, while providing the services, to what extent do we really use the available approved guidelines into actions to provide the quality of services? So as primary role of the PO-RALG, we see that as a challenge. Just consider, as you say, that when a patient goes into the facilities, the guidelines state very clearly. If it's history taking, if it's lab investigation and so forth, but to what extent do we implement what has been analyzed in the guidelines? So as you say, most likely only 60% or roughly 50% of what is in the guideline is really implemented at the field. But also, as a PO-RALG, our role is to monitor and evaluate also the interventions at the subnational levels in collaboration with you as potential stakeholders. Now, we have a challenge also in that role of monitoring using the accurate data, using the evidence derived from the implementation that will influence implementation in practice. And our expectation in such, our desired outcome is improve the quality of care. So we have a challenge of that area, but that is the law. And when I'm talking about the role and the challenges, I'm talking about the rationale now of effective implementation of the policies and policy guidelines, of having implementation research or implementation science at the subnational and the primary healthcare levels in general, but influencing not necessarily advanced researchers. We are talking about the primary care practitioners. This could be just, not very advanced, but just basic practitioners. How can we now make them use data to make a decision that they are well informed? So those are some, just a few laws of the PO-RALG that align with the rationale of why do we now promote the already known global challenge of implementation first, but capacity of implementation research to the PhD levels, but implementation in practice, which is a process that is integrated on the day-to-day, that is routine activities by the primary healthcare staff. Now coming to the second part of the question from the moderators, the potentials of having a roadmap. So for those who do not capture clearly what Ulrika was saying about a roadmap, we're talking about the global challenges of just implementations. There is that problem. You can even assess yourself. To what extent you implement, put correctly into implementations, all the available guidelines, policies, all SOPs in day-to-day provision of services. If you assess yourself, you can see maybe only 50% of the guidelines that are accurately put into actions, accurately translated. So now we want to encourage how now the decisions can be influenced by evidence-informed implementation practice. So this is very important for us, because most often you have been seeing the researches that are like top-down and top-down approach.
So,
but yes. But I can go to the side. Thank you very much. So, but working together the PO-RALG with academic institutions, just a minute, and thank you very much, moderator, you're very strict. Working with the academic institution, this is an avenue for us to collaborate with academic institutions in the area of implementation research and implementation practice, collaborating with the research institutions and the other stakeholders, And equally, to finalize, this is, to me, is also a resource mobilization tool, because the UNICEF has supported us with other partners in their part. But I call upon other partners, not necessarily implementing partners, the research institutions, the individual persons, the families, to join hands in strengthening capacity of our PHCs in terms of research capacities, but in terms of transferring the research capacities into improve the quality of care through implementation practices. So thank you very much, moderator.
Thank you very much, Dr. Rashid, for that well-elaborated and insightful experience on implementation, research, and practice. So, Dr. Irene, what is the linkage between quality improvement and implementation research, as well as implementation practice, as we build the sustainable systems, given your expertise? In hardly 2 minutes, karibu sana.
Thank you so much, Mr. Moderator. Because we don't have much time, I think I'll be quicker. I want to tell you to make sure that you all understand that the linkage between quality improvement and implementation research is really essential for advancing health system in Tanzania. And looking at quality improvement usually focuses on improving process and outcomes within healthcare settings. And quality initiatives usually are applied using cycles of testing, refining, and scaling up interventions with the focus of improving, immediate improvement of health service delivery, patient care, and efficiency. While on the other hand, implementation research is broader, and it's based on implementation theories with the aim of understanding what works and for whom, under what setting, and why some interventions work in a certain settings and why some are not working, and how can we sustain them. So coming to your question on the linkage between the two, I'm going to point only 3 points, which are really important for the sake of time. So the first one is on evidence-based practice. So both implementation research and quality improvement focuses on addressing evidence-based practice with the aim of improving service that is being delivered. And the second point is on contextual adaptation, that both emphasize on adapting to the local context. That quality improvement will help you test the intervention, while implementation research, it will help you understand the barriers and adapters as to why that intervention either is working or why is it not working. Yeah. And on the other part is about a feedback loop, that quality improvement projects will produce data, and those data they will be used now with implementation research to find out, like what I said, the data that we produce from the quality improvement projects.
Can you wind up?
They will help us understand, by using our implementation research, we'll be able to understand whether the interventions that we're using, are they helping us or not helping us. So with this forum, I think it's really important for health providers, the RMOs, TMOs, and medical center charges to understand the importance of implementation research. That is really important for them to be able to use the evidence that they get, the evidence information that they get from the research, and to be able to use the information in order to improve our quality of care.
Thank you very much, Dr. Irene. So please, Ms. Chipore, you are the expert of monitoring and evaluation. What are the key indicators that can be embedded in the presented roadmap in order to enhance implementation research and practice in the context of Tanzania? Hardly 2 minutes, if you can summarize. Karibu sana.
Thank you, Dr. Pius. Because time is very short, I will just speak in a summary. As we saw from Oka's presentation, we have a draft of the roadmap. We'll finalize it, and the roadmap has a number of strategic objectives, about 5 of them, which have also been mentioned here. That is where you saw the integration and linkage with academia, but you also saw a point where she spoke about creating or identifying entry points at different levels of the health system. So from those different points, we're going to have, from the strategic objectives, we are going to have interventions and key actions, some of which she also displayed here. From the key actions, as you may understand, we must have indicators that will help us track the progress of whether we are on track, how are we doing in regards to operationalizing or institutionalizing PHC in our IR implementation research and implementation practice in PHC. So some of these indicators from different levels will be, for instance, for the national level, the roadmap. Developing a roadmap is one of the indicators. Developing the SOP is one of the indicators. Stakeholders meetings such as these ones, forums on IR and IP is one of the indicators. So the indicators will help us track the number of forums, track the number of stakeholders that have been mapped, track the capacity building programs that have been conducted or coordinated by the national level, the academia, as we say, we are going to have linkage with them, the number of curriculums that have been developed by the academia colleagues, but also things like, apart from the capacity building, how well have we been able to utilize the entry points? Like we said, everything starts with the planning, so we already have systems to scrutinize the national plans. So from the CHP, starting this financial year, we're going to look into whether implementation research and implementation practice activities have been included in our plans. And that will be a requirement for passing the CCHP, as we understand. Also, at the regional level, RR or research is one of the key RHMT functions. So we are also going to look into RHMT plans to make sure that IR and IP are part of the RHMT activities. And the same is going to apply for the RHMT and the CCHP and CC swap reports that will be coming over to the national level. That means all the health interventions, social welfare interventions, and nutrition interventions will have to include IR and IP. So that is what we are looking forward to. Thank you.
Thank you very much, Ms. Chipore. So back to Kasusu. As an academician from the Muhimbili University, what are the strategies do you recommend for bridging the capacity gap in implementation research and practice for the primary healthcare in Tanzania? I know you can summarize that in 1 minute.
Thank you very much. I'm going to try and avoid the wind-up statement. Thank you very much, Piers, for that question. At the University of Business, we have 3 main core functions: research, training, as well as services or consultancy. So clearly, capability or ability of the various stakeholders or players within both implementation practice and implementation research, they have to have a core ability to do things. And from the academia, we believe that this is an opportunity to create tailor-made short courses or workshops, but also this is an opportunity for development of continuing professional development courses utilizing various novel mechanisms, including media and e-learning platforms that we already have, to ensure that practitioners that are on the field can access this information and update their knowledge and understanding as to what implementation practice is. Because as it has been previously stated, the intention is not to transform everybody into a researcher, but to allow everybody to understand the importance of using evidence while making decisions at their place of work. Case in point is we're in this hall right now, we're all sweating bullets. And the only intervention that was required was just opening those flaps, you see? And only a person who was in this room could conceive the need of opening these flaps in order to ensure that there's sufficient aeration. Other than that, I'm standing here as part of the academia, policy, and practice partnership. Because we need to make sure that whatever it is that we are implementing or what we're researching is co-designed, and it is really responding to both the policy needs, but also what the practitioners on the ground would request as something that is really pressing, requiring change. I submit.
Thank you very much, Dr. Kasusu, for a well elaborated insights on that. So please pass the mic to Professor Carol. I introduced you before you came here. So as the implementation research expert, as well as a professor from a private academic institution, what role do private academic institutions play in shaping implementation research and the implementation practice capacity for the primary healthcare in Tanzania? And how can public-private partnership enhance the efforts? In 1 minute, you can respond. I know you can just summarize in that. Correct, sir?
Yeah, so thank you very much. I work with the St. Francis University College in Ifakara. As a private university, our laws are not different from what is done by the public institution. That is training, research, and service. Now, when it comes to research in our side, especially for implementation research, we design short courses on implementation research, but also we are trying to see how we can embed implementation research in the curriculum. Yeah, so that is one when it comes to training. But when it comes to service delivery, our role is to actually make sure that we support various institutions that are developing interventions, so that we develop theory-derived interventions, theories that are informed by interventions that are informed by theories, because implementation research requires that at one point you are guided by theories. As a private institutions, we actually do work with the government. That is when it comes to PPP, building capacity to public health workforce on various areas. And when it comes to implementation research, we have partnered, for example, with the PO-RALG, but also with the Ministry of Health, designing various guidelines and materials that are actually very important for implementation research and implementation in practice. Thank you.
Thank you very much. Dr. James, how can research and publication be better aligned with the practical needs of the primary healthcare development? And what are the necessary steps that can be taken to ensure that the findings are being taken into action, or the knowledge translation?
Thank you very much. So, as a research and publication coordinator, but also as a member of National Health Research Affairs Committees, one of the biggest interests for us would be we need some evidence that will feed into the practice. So there must be a very clear relationship between the information practice and information research. What comes out of the information research needs to feed in the practice. But at the end of the day, we're interested in improving the practice and quality of care. So every knowledge generation, evidence, need to be we need to work together. The aspect of co-creation is critical. And of course, during the development of theory of change and the concept of the proposal for the information research, we need to work together with the people who at the end of the day are the user of that findings. So at the end of the day, all this one will be well received and fed in. And one of the good practices is also to work together collaboratively with the implementers and also the policy makers from all steps, from the co-creation to implementation at the end of the day. And the other thing that is, I should answer your second question, the capability when it comes to knowledge management. People think as management is just a broad term, but it's something that needs capability in terms how really to make your evidence in a way that can be utilized. I'm talking about here how to create some knowledge products, the false brief, analytical fact sheets and the likes, all the knowledge products. It's very, very important to build in-house capabilities so that at the end of the day, we're able to really make those knowledge products and then use at the end of the day. Asante sana.
Asante sana. So back to the audience. If you have any question, anything to comment about implementation, research and practice, 3 questions will be around, and just hit direct to the question. The mic, please. Anyone to assist passing the mic?
Yeah. Thank you very much, moderator. Just a comment. Yeah. So thank you for the presentations and discussions here. This is a comment. I see an opportunity, perhaps missed opportunity sometimes, involving NGOs, CSOs, particularly doing advocacy. So I was involved at one time working for a local advocacy NGO in the health sector. And we did quite a lot of evidence-based advocacy, so we pushed certain agendas. And that one would see some traction in translation that the government is for. So sometimes it's difficult working within the government to change something. But if you link up with NGOs, CSOs who are doing robust advocacy work and evidence, they can sometimes push that agenda. So I think that's an opportunity. And also, in terms of the landscape opportunities,
because of time?
In terms of landscape opportunities, I saw a missing link to Ministry of Health has that structure, the TC swap. So there's normally that joint annual sector review. I think there's opportunities there in terms of having a coordinated research agenda from which people can draw from in that way. So I think those are opportunities. Thank you.
Thank you very much. Dr. Leonard Subi, please. Pass the mic to Dr. Subi. The next, maybe we have it ready for the sake of gender. Okay. Karibsa.
Thank you very much, moderator. I commend the good work from the speakers. Mine are few. First, the topic is so good. It is commendable. But I have some few observations towards 2030. I think our main focus on the SDGs, how are we going to achieve, especially on the issue of maternal, newborn and child health, including vaccination. But second is on prevention and control of infectious disease, especially TB and the others, and the issue of health system. So generally, from this topic of implementation practice, I think we should focus on that. We have invested a lot on infrastructure and equipment in the primary health care facilities. But now we have to change our focus on the software aspect, on the issue of human capacity, especially on supervision, mentorship, but also to ensure that they do the same. So how do we make that? Let us focus on the resource now to ensure that the CHNTs, the RHNTs, they have good capacity to support more than 10,000 primary healthcare facilities that are under PO-RALG levels. So my big comment was just there. So let us now have a change. It's not a question, but it's just a comment. Thank you very much.
Thank you very much. Maybe because you're nearby. Ibsa.
And thanks first for the very clear and concise explanations of this difficult area of QI and implementation research. I have a question to somebody who is in fact not in the panel, and that are the donors. The implementation research needed to do a multifaceted QI approach. IT, training, supervision all come together. May not link very well with the attitudes of donors who prefer a single facet. They like to fund training, they like to fund IT, they like to fund that. So how can we change the attitude? Also the donors understand that only a multifaceted approach will lead to good implementation research, will lead to a good outcome. That is a question I'm still struggling with. Thank you.
Thank you very much. We still have a lot of hands up, and for the sake of time, we are out of time. Maybe some of you just need to contact the speakers to gain more understanding. 1 minute.
Thank you very much. My concern about the research is the originality. What I have experienced is, like, to put it in a dramatic way, there is a composer somewhere outside. He comes with the funds, and then we dance to the music. So originality. Then, you are research. I see people bring PhDs, a lot of research PhDs. But can you give concrete examples? What research has been transformed and brought really changes, for example? There are a lot of research, but have they really transformed? And in concrete terms, can you give example of your experience in university and so on? Which research actually has changed the situation? Thank you.
Thank you very much. Maybe my panelist, for half a minute, you just respond, and just if you don't have something to respond, maybe Ulka can start with you, then Professor Karol, then we'll be winding up.
Okay, let me just quickly say something about all three comments and questions, and then welcome anyone who's interested to discuss with us throughout the day. On the missed opportunity of the joint annual health sector review, where was the colleague who was talking? There you are. I think it was actually, you'll find that we had listed it as one of the entry points. I just had to go super quick, but that's exactly the kind of place where we would want to see these things. On Dr. Subi, absolutely, you were talking about the focus areas, what we need to focus on. I think this approach is very generic, so we're trying to say that in some ways, whatever our SDGs, whatever our priority areas, we need to get from the decision of what to do to how to do it. So it's not in opposition to that, and really changing the software, like you said. I like that. Eric, on donors' attitudes, I think this is very key, and I think, and this links to the last question as well, on has research ever changed anything? Ooh, that's a hard blow to all the academics in the room. I think yes. I think there's actually quite a lot, there's quite a lot of evidence from implementation research worldwide. It's budding evidence that if you engage implementers from the start and you feedback quickly, you can change what is happening during the course of a program. And I think that's what we also need to show the donors, that this actually improves the outcome of their investments.
Thank you, Dr. Olka. Dr. Rashid Mfaume, if you can comment.
Just to respond on two issues. One is engagement of all of us, every single one of us, including the NGOs in the advocacy. Very important. We don't have equal understanding of the implementation of research, implementation in practice. So we agree with you. As a PO-RALG, we will continue engaging as many stakeholders as possible. The issue of formulation, Dr. Eric, you are very right. Yours was just an opinion. That not only changing the mindset by the PhD staff, by the PhD, the RHMTs and CHMTs in terms of implementation practice, but every one of us, including the funders. So thank you very much for that.
Thank you very much. Professor Karol, in half a minute to respond which research has changed the practice. We have a lot of publications and so forth from PhDs. Can you respond from that, please?
Thank you very much. Yeah, so research evidence to practice is one of the areas which is still a challenge. And at St. Francis University College, we are working on a project that will try to bridge this gap. We are setting up a rapid response service for policymakers and practitioners, when they have a research, a policy question, or they have a practice question, they can link to a rapid response service, and then it's synthesized and then it's brought to practice. But when it comes to research that actually changed life, we have several examples. For example, in Tanzania, you can talk of the TENCO project. That is one of the remarkable research that changed a lot, especially when it comes to the primary health care. Yeah, so we have several, but we still have a way to go to make sure that all research evidence is used in practice. Thank you.
Thank you very much. James, in half a minute, as we are we'll be winding up in 1 minute to come.
Thank you very much, moderator. So just to echo the issue of the role of Minister of Health, we know already for sure they are in charge for the development of even the National Health Research Agenda through the NIMBU. So this is kind of a way of operationalizing that one. And at PO-RALG we have kind of an open door policy for the university students, PhD masters, who are required to conduct some dissertations or theses, so that we can develop together their topics. So we've done already that one, and we have a MOU with BUHAS, we have MOU with UDOM, we have a MOU with Zumbe, and everybody who wants to work with PO-RALG, you are all welcome. And the second issue that was raised by Dr. Subi, the issue of integration, we are also implementing that one as a pilot in Kigoma. So we are doing what we call a 3-in-1 model, where we are really experimenting the issue of how can we integrate the concept of leadership, mentorship, and performance contract. That reflects a number of indicators within the SDG, so that we can see how that one works, so that we can improve the SDG.
Thank you very much, my esteemed panelists, and this marks the end of our forum. So to wind up, we had heard from the panelists on the need of evidence-informed practice for us to just navigate in the achievement of universal health coverage. But again, the need for bridging that gap, what is available and what is actually put into practice, the need of intervention, evidence-informed interventions, the need of capacitating the healthcare workers, and evidence-informed practice and implementation research, but again, overall, in the improvement of quality of care at the primary healthcare facilities. So please, again, just help me to appreciate the panelists as we get to the end of this forum. Asanteni sana kwa kushiriki. Maybe we have the last photo.